Right, Assalamualaikum and good morning, everyone. Right, firstly, my name is Abdul Azim bin Abdul Aziz, and I'm a last year degree student. So, for now, I'm going to present my case presentations on acute myocardial infarction on my pre-hospital care posting in Jabatan Kecemasan Hospital Lampang. All right, so without wasting our time, let me start my presentations for now. All right, so let's move on to the next slide. All right, all right, acute myocardial infarction. Okay, basically the acute myocardial infarctions, also known as a heart attack, is a life-threatening condition that occurs when the blood flow to the heart muscle is abruptly cut off, causing a tissue damage. Lah. All right, so this is usually the result of a blockage in one or more of the coronary arteries, and then a blockage can develop due to a buildup of plaque, a substance mostly made of fat, cholesterol, and cellular waste product, or due to a sudden blood clot that forms on the blood blockage. Lah. Alright, so according to Moon, EU and Red Kai 2018, AMI is a life-threatening condition that causes cardiac tissue damage due to restrictions of blood flow to the heart muscle in the coronary arteries. Alright. All right, so we move on to my case presentation. All right, for my case presentations on November, on the 11th November 2021 at 1 p.m., a friend of Mr. J called MECC Ampang to report a case of serious chest pains out at Lot 45, Jalan 18th over to a Kampong Pananjaya. All right, so Mr. J is a 48 years old Malay guy who works as a teacher and has one wife and three children. All right, for the history of present illness, Mr. J is currently in a pre-syncopal state when the respondent arrived at his home, and the patient and the Mr. also complaining and having a chest discomfort and other complaints of nausea, vomiting, and dyspharesis and drowsiness as well. By the way, the sickness or discomfort has been present for the past 30 minutes, and Mr. J has not been relieved by a single dose of sublingual GTN. All right, for the past medical history, Mr. J is underlying ischemic heart disease and hypertension so far. And then Mr. J was under a follow-up at Surgeon Hospital. By the way, his most latest heart attack occurred in January of last year when he was diagnosed with myocardial infarction and admitted to the Surgeon Hospital. By the way, there is no history of drug use or drug allergy, and he has no prior surgical experience, and he has no history of COPD or asthma, and he was not on any vaccinations yet. All right, for the family history and social history. All right, for the family history, his father got heart disease and hypertension also. And for the social history, Mr. J is average socio-economic status, married guy, and he is a heavy smoker, 18 cigarettes per day, and denies addict drug. All right, for the examinations on the general appearance, Mr. J is presenting to us with a fully alert conscious BCS 15 over 15, pink and head versions is a moderator, and for the vital sign BP is 100 is 65, pulse rate is 90 per minute, SpO2 is 98% under room air, the temperature is February 36.8, the pain score is 7 per 10, and RR is a mild tachypneic 23 per minute, and the GCS is full 15 over 15. All right, so this is the investigation that we did for him, and this is the for the FBC. All right, for the FBC, the white blood cell is 10, hemoglobin is 17.1, hematocrit 43.5, and the platelet is 265. All right, for the RP, The potassium is 3.7. Okay, all right, and then for the creatinine is 90.3. All right, for the aspartate transferase is 21.5, troponin T16 or for the coagulation profile. Proton mean time 14.8 second, INR is 1.2 second, and for the VVD pH is 7.38, bicarb is 25.1. All right, for the X-ray, we saw for the haziness and myocardiomyopathy, and for the ECG is dyskinesia at the anterior chamber. By the way, this patient has been diagnosed with 3 classifications of acute anterior myocardial infarction, which is ST elevation myocardial infarction staining. Okay, for the management for this patient, for the for the ATSIN, the primary survey began with danger response, airway breathing circulation disability and exposure. As soon as the responder complete the brief history, the responder is wearing for PPE, and the use of PPE such as mask, glove, and apron is critical to protect responders from potential hazard posed by patient. All right, call the patient and make sure he is completely resting on the bed. Okay, patients then are connected to an automated external defibrillator, AED, or cardiac monitor, blood pressure monitor, SpO2 monitor, and ECG tests performed on a regular basis in order to detect changes in rhythmic or heart patient. And then the vital sign was checked. After that, the patient's management includes oxygen therapy, which is dependent on the patient's need. In this patient condition, the oxygen is provided up to 3 liters per minute by using a nasal cannula to help patients breathe and relax. All right, to avoid shock and ensure the vein is open, we give the patients a regular saline intravenous IV tube as a maintenance through IV big pranula mounted before arriving to the emergency department. All right, for the management in emergency department, the most vital aspects of the patient's care was continued, which is the administrations of the painkillers. All right, the medicine such as IV morphine 2.5 mg has been given status and can be administered on a regular basis based on the patient's level of pain and vital sign. Next, severe medications such as clopidogrel 300 mg tablets, aspirin, or acetylsalicylic acid 200 mg tablets, and 0.5 stats or immediate sublingual GTN are frequently required for administration. Other than that, the patient is given subcutaneous pentaferrin sodium or erythra 2.5 mg stat, which is an anticoagulant that acts as a low molecular heparin. The patient is given IV pantoprazole 40 mg and IV metoclopramide 10 mg to reduce the acid in the stomach and to relieve symptoms of reflux. Otherwise, medical officers consult a cardiologist for expert guidance on patients, and then these patients PCI was decided to be performed at National Hospital Intensive Cardiology Laboratory ICL. Okay, and then finally, this patient was admitted to the coronary care unit CC ward for intensive care and continued therapy and management. Okay, by the way, this is the ECG in emergency department. So we noticed that there is a ST elevations on the V4, V5, and the V6. Yeah. Okay, for the differential diagnosis, which is for the acute gastritis, costochondritis, unstable angina, myocarditis, and pericarditis. And for the conclusions, AMI will occur regardless of age, period, or conditions. So in terms of risk factors, investigation, differential diagnosis, patient care, and other aspects of this disease, we may know and gain significant information from the case of this patient. Pre-hospital care and emergency service play an important role in the treatment of AMI patient. The most crucial priority is the treatment time for the golden hours. As a result, having a qualified and skilled medical team of practitioners is critical in order to deliver more efficient patient care. I think that's all from me, and thank you so much for the listening. Thank you.